Welcome everyone. Last day of April. It's going to be a hot one, I think. I'm very excited to have Dr. Tommi Gaines today giving us a talk about HIV prevention in American Indians. I'll let her talk about that in a sec. I do also want to brag about Dr. Gaines that she got us her slides a week in advance. So we actually could look through them and give a very smidgen of feedback. But so people can do it. It's great, and I think it's helpful for everyone. So just a plug for that, and thanks for Dr. Gaines for doing that. So Dr. Gaines is an enrolled tribal member of the Navajo Nation and an associate professor in the UCSD Department of Medicine. As a trained biostatistician, her research is focused on applying statistical and spatial methodologies to address the context of health among marginalized and vulnerable groups. Her research involves cross-disciplinary partnerships to examine prevention and treatment resources for substance use and HIV. Currently, she is leading a 4-year mixed method study on HIV/STI awareness and prevention among reservations-based American Indians in Southern California. With that, I will turn it over to Dr. Gaines. Questions in the chat for either directly to me or the whole group if you'd like. And Tommi, I'll give you like a 10-minute heads up at the end if you're still going so we can have some dialogue.
Okay, great. Thanks. Jill. And I have to say, I can't take full credit for getting the slides available to you a week in advance, since this is actually a presentation I gave late last year. So hopefully this is new for many of those who are on Zoom today. But this is a presentation based on some work that I've been doing over the past about 5 years, looking at the HIV epidemic within our American Indian and Alaska Native population. So for today, the title of my talk is Nobody Really Talks About Any of It, HIV Prevention Among American Indians and Alaska Natives. And I just want to mention the funders on this work. Again, this is work that has spanned a couple of years, so there's been a couple of different funders involved here, but all of them link back to the National Institutes of Health. So just to start off with, in terms of the American Indian and Alaska Native population, they represent less than 2% of our overall US population. Approximately 5.2 million people identified as Native in our last census count, not the 2020 as we're still waiting for that, but the 2010 census count. And in terms of where the Native population is located across the nation, we have a large presence of Native Americans here within our southwestern region. So the turquoise areas indicating places that have at least 100,000 people self-identifying as American Indian Alaska Native. And California itself is a state that has the largest number of people self-identifying as American Indian or Alaska Native. In the 2010 census, it was about 14% of all natives resided here in the state of California. Now, as a group, Native Americans are a highly diverse group of people. Currently, there are 574 federally recognized tribes, and this number increases if we were to consider tribes that are recognized within their state, but not by the federal government. And I want to also mention that in terms of tribal membership, it's really a political designation and not a racial one. And the reason being is because of the relationship that tribes have with the US government. So it's not merely one to say that I'm American Indian or Alaskan, American Indian or Alaskan Native ancestry, but really it's about having that tribal membership or being considered a citizen of a particular tribe that defines tribes in the United States. But as I said earlier, it's a very heterogeneous, diverse group. And by that, what I mean is that tribes have different languages, cultures, and belief systems, as well as different government structures and population sizes. So Jill, in the nice introduction she provided of me today, she indicated my Native heritage. So I'm an enrolled member of the Navajo Nation, but I'm also part Hopi. And these are two tribes that are located in the northern region of Arizona. The Hopi tribe itself is situated and it's encompassed around the Navajo Nation tribe. But both the Navajos and Hopis, they speak different languages. They have different types of ceremonies and practices. Populations vary widely between my two tribes. The Hopi tribe is about 18,000, whereas the Navajo tribe is over 300,000. So just a lot of diversity just within my own cultural heritage and throughout the rest of the United States when we look at tribes. But despite this diversity, there is a common experience across tribes, and that's this history of colonization here in the United States, a history of forced assimilation, loss of languages, as well as culture, a history of violence towards the Native people, as well as racism and trauma, both historical and current traumas. And another thing that's a common feature across many tribes is that Natives tend to reside in urban populations. Again, based on 2010 census data, over 3/4 of the Native population did not live on their reservation tribal lands. Rather, they tended to live in urban or semi-urban areas. So here's just a map displaying some of the metropolitan areas within our country that have the largest share of a Native American population. And this map itself isn't just based on people that self-identify as American Indian or Alaska Natives, but those who also self-identify with a particular tribe that has been federally recognized. So again, based on the census data, about 1.5 million Natives who self-identify with a tribe reside within a metropolitan area. And these metropolitan areas with the greatest percentage of urban Indians include the Phoenix, Mesa, Scottsdale area in Arizona, the Tulsa, Oklahoma area here, and then finally Los Angeles, Long Beach, Anaheim metropolitan area. But even if we just zoom in here to our three counties that are the counties that make up Southern California, so thinking about LA County, Orange County, San Bernardino County, Riverside County, as well as San Diego County, this is a region, Southern California, that has a high presence of a Native population who also self-identify with at least one federally recognized tribe. In addition to just geographic location, some demographic information regarding this population is that Natives are a group as a whole that endure unique socioeconomic conditions that increase their risk for mortality and morbidity. And what I mean by that is, in terms of demographics, it's a population that tends to be younger than the overall US population. The median age of American Indians and Alaska Natives is 29 years compared to 37 years for the US population. A higher percentage of Natives reside in female-headed households, about 12% compared to 7% in the general US population. There's also lower graduation rates within this group, 77% compared to 86% in the US population. And also a higher percentage of Natives living below the federal poverty level. In this case, about 28% compared to 15% in the US population. And I mentioned these demographic conditions within this population because these are factors that are associated with HIV risk. So here is a graph displaying the rates of HIV diagnoses between 2014 and 2018 among adults and adolescents by race ethnicity. And in looking at this graph, what we see is that the rates of infection for most racial ethnic groups have started to decrease and then stable. So looking here at African Americans, multiracial, and Latinos. For American Indians and Alaska Natives, there's been a bit more variation over this 5-year time span of looking at the rates of diagnoses. So we have the rates increasing from 2014 to 2016 and then starting to decrease thereafter, where rates of infection in 2018 is similar to what it was back in 2014. And overall, with the latest census, or excuse me, surveillance data, when it comes to the rates of infection for Natives, they make up less than 1% of new HIV diagnoses. And so given this small proportion of infections relative to other groups are often overlooked in HIV prevention efforts. But this is a group that does endure significant HIV-related disparities. And so what I mean by that, let's just present some of the data that we've seen come out of the CDC surveillance data in terms of disparities endured by this group. So between 2010 and 2017, there was approximately a 39% increase in the number of new HIV diagnoses for American Indians and Alaska Natives. And during this time period, the groups primarily driving that increase were Natives between the ages of 25 to 44, as well as male Natives. Another thing that was occurring during this time period is Natives being more likely to be living with an undiagnosed infection. Specifically, 24% of Natives compared to 16% of the general US population have been found to be living with an HIV infection, but being unaware of their infection status. In addition to just the burden of HIV, another factor contributing to elevated risk for HIV are the high rates of sexually transmitted infections within the American Indian and Alaska Native population. So here's another graph showing some data from the latest STD surveillance report. And on our left, we have the rates of chlamydia reported by sex as well as race and ethnicity. And then on the right, we have the rates of gonorrhea, again, reported by sex and race ethnicity. And for both men and women, what we see is that Native Americans have the second highest rates of chlamydia, as well as the second highest rates of gonorrhea. And again, this is concerning because it's an indication of sexual practices or unsafe sexual practices that can also be linked to increased HIV risk. Now, some other factors beyond STI infections that contribute to increased risk amongst the American Indian Alaska Native population are outlined here. So first factor being stigma. Stigma when it comes to sexuality and sexual health, and not really wanting to discuss these issues, or desire for tribal communities not really wanting to discuss these issues. Another factor linked to HIV risk is confidentiality. Very often when we're talking about our tribal communities, there's issues around confidentiality because our tribal communities are often situated in small towns where people want to know one another, and there's concerns around privacy being breached. And I'll get a bit more into stigma and confidentiality later on during this hour when I present one of the study I'm currently conducting, a mixed method study. Another factor contributing to increased risk is high rates of alcohol and illicit drug use. American Indians and Alaska Natives have high rates of alcohol use as well as opioid use and methamphetamine use. And these are all factors that contribute to sexual behaviors as well as risky drug use behaviors that in turn can elevate one's risk for HIV. Another factor contributing to risk is a lack of culturally appropriate programs. Again, recall earlier I said that there's over 570 federally recognized tribes, and each tribe has their own cultural practices, their own ceremonies. And so it's really the lack of culturally appropriate programs is really pointing to the need to develop more tailored interventions towards specific tribes. And then last, data limitations. When it comes to our surveillance data, very often we don't hear about the Native American population. And part of that is because of trying to protect individuals' privacy or their confidentiality. Being a population of less than 2% in the United States, it's not surprising that when we collect samples, there's not a lot of Natives within those data sets. And so often what we see is that data is either suppressed for Natives or they're lumped into an other category, which makes it difficult really to see how large the burden of HIV is within this population. And so in terms of the HIV epidemic and what's been done so far, there have been a lot of initiatives to look at HIV and how can we improve just the identification, the surveillance efforts around HIV, as well as improvement around prevention and treatment for the Native population. And so I'm using here as an example just two reports that came out over a decade or less ago. And this first report here on the left was generated by the Indian Health Services, which is a federal program within the Department of Health and Human Services. And Indian Health Services exists to provide healthcare services to members of federally recognized tribes. And so this report or this work plan came out over a decade ago. And in this report, it acknowledged the lack of prevention and treatment that was needed at that time for the Native American population. And essentially in this report, the take-home messages were, IHS needs to mobilize its resources and to do so through developing policies specific to IHS that would help implement health programs around prevention and treatment. And then just a couple of years later, the CDC released its own report that was really acknowledging the limitations that we have in documenting the burden of HIV within the Native population. And so this is a report around improving HIV surveillance. And in this report, what some of the recommendations made were that there should be more routine testing within this population. That again, despite appearing to have a low burden of HIV infection, that this is a group that does experience disparities that put them at risk for infection. So we need to start testing more. That's one of the recommendations out of this report. As well as reporting HIV infections back to tribes and to organizations that primarily serve American Indians and Alaska Natives. Another important feature that came out of this report is a need to reduce racial misclassification, which really resonates here in California, particularly in Southern California, where very often American Indians and Alaska Natives are multiracial or identify within the Hispanic category. And so the need to improve racial misidentification within the Native American Indian and Alaska Native population. And then finally, a recommendation of just improving data analysis and looking at ways of to improve techniques when working with small population sizes. So it was within this backdrop that, seeing these reports around the HIV epidemic, having an interest in addressing this because the data at the time, and this would be about 5 years ago, indicating that American Indians and Alaska Natives did endure significant HIV-related disparities when it came to testing, when it came to treatment, and when it came to survival. But I started off with one study that then cascaded into 2 other studies. So what I want to do now is share some of the information that I've gained over the past 4 years of conducting 3 studies within Southern California, each looking at different aspects of the HIV epidemic within the American Indian and Alaska Native population. And so the first study that I'll describe to you is based on looking at travel time to reach HIV resources here in San Diego County. And then the second study that was conducted thereafter was to look at HIV testing within cisgender women who underwent voluntary HIV testing here in San Diego County. And then the final study, which is currently ongoing, is one that is a mixed method study that looks to identify local level prevention strategies within our Southern California tribal communities. So starting off with this first study, the motivation behind this study was really around looking at tribal reservations and seeing where are HIV resources for our tribes. And the reason for that is because very often our tribes in the United States are located in more remote and rural regions of our country. And we also know from surveillance data that rural regions have experienced an increase in HIV incidence over time, but HIV testing rates remain low within our rural regions. And so the goal of this study was really to look at geographic accessibility to testing and medical care for the American Indian and Alaska Native population. And it was a study that was situated here in San Diego County. And part of the reason for that is because San Diego County is ranked 12th amongst all US counties as having the highest or the largest American Indian and Alaska Native population. So this study was really an ecological analysis in which we looked at where are HIV testing and treatment services in our county, and then estimating the time to reach those services at the census tract level. And then also looking at characteristics of the clinics that did provide testing and treatment services. What did those clinics look like in census tracts where we had a large presence of American Indians and Alaska Natives relative to the census tracts in other parts of our county? And so here are the results of conducting that first study. So on the right, we have a map of our county. And you could see that the map is colored in different colors of pink all the way to dark red. This is our map that is disaggregated into census tracts, where the darker colors indicate census tracts that have a larger proportion of residents that self-identify as American Indian and Alaska Native. Also on this map, I have outlined in this neon yellow our American Indian our American Indian tribal reservations in the county. There's a total of 18 federally recognized tribes in the county. And as you can see on this map, a lot of our reservations are also situated in places where we have people that self-identify as American Indian or Alaska Native. And then the blue dots here indicating HIV testing locations throughout our county. Now, this is there's a limitation here because the HIV testing locations is based on data that was pulled from hiv.gov. So this doesn't provide locations of, for example, private doctors providing testing. But what we found from conducting this study, the main finding was that census tracts with an American Indian reservation, that those census tracts had a longer drive time to reach HIV testing and care. Specifically, what we saw is that census tracts with the reservation, on average, took 16 minutes to reach HIV testing, whereas other census tracts without a reservation, on average, took 5 minutes to reach HIV testing. And then when it came to HIV care, drive time was substantially larger. So 40 minutes for census tracts with the reservation compared to 10 minutes in the rest of our county. So we are seeing this spatial disparity just to reach HIV testing and care resources. But then also when we looked at characteristics of the clinics, we also saw some meaningful differences. And that being that clinics that were near reservations, they tended to be less likely to offer free HIV testing compared to other clinics in our county. They are also less likely to have extended business hours, so not being operational on a weekend or after 5 p.m. compared to operational or business hours for the rest of the county. And then lastly, they were less likely to offer HIV care within that clinic. So again, if someone tested positive for HIV within a clinic near the reservation, they would more likely have to travel outside of or go to a different clinic, so outside of their area to receive care. Now that study I just presented to you was purely ecological. We were looking at data in the aggregate. And so this next study built off of that first one because the interest now was to see, well, what are people doing in terms of testing? We know that these resources are not in areas of our county where we tend to have a large presence of American Indians and Alaska Natives, but do we see any differences when it comes to individual testing patterns? And so the goal of the second study was just to compare that testing patterns between Native and non-Native individuals. And this particular study was focused on cisgender women. And the motivation behind this came from the 2016 HIV surveillance data, which showed that within the American Indian and Alaska Native population, women accounted for 24% of HIV diagnoses. But when we look at the overall population of people who are infected with HIV, in that situation, women only account for 19% of diagnoses. So already seeing a clear difference here between Native women and non-Native women in terms of infections. And so this was a study that was conducted with a program that Dr. Susan Little leads called Good to Go. And this is a retrospective cohort study of cisgender women who were participating in community-based, voluntary and confidential HIV testing program that spanned between 2008 to 2018. So here are some results of that study. And so over this 11-year time span, there's about 250 Native cisgender women and 4,500 non-Native cisgender women. In terms of residents, we didn't see a difference between women, Native and non-Native women regarding their rural residents versus, urban residents. Similar proportion Native and non-Native living in rural regions of our county. What we also didn't see a difference in was sexual behaviors between Native and non-Native women. So a similar proportion of Native and non-Native women reported always using condoms within the past 12 months. A similar proportion reported averaging more than one sexual partner in the past month. And a slightly higher proportion, but not significant, Native American women reported having a history of STIs. Now, where we did see a difference was in HIV testing patterns. So for Native women overall, they were less likely to have reported having a prior HIV test before enrolling in this program of voluntary HIV testing. And this was true for Native women residing in rural areas as well as urban areas. So regardless of residential environment, Native women were just less likely to have a history of a prior history of HIV testing before enrolling in this voluntary testing program. And this was despite Natives having a similar risk profile as non-Native women. Just overall, there was lower testing going on within this group. And so these two studies were being conducted at a time that this publication came out in Public Health Reports that looked at new diagnoses of HIV amongst American Indians and Alaska Natives being served by Indian Health Services, where again, Indian Health Services exist to provide medical care to tribal members of federally recognized tribes. And so in this publication, some of the information that came out is things that I've already shared with you earlier, and that diagnoses were significantly increasing in certain demographic groups, that being being males and certain age groups. But one of the things that came out, which out of this publication, which echoed some of the things that were just being discussed with the ending the HIV epidemic, is the need to look at services and provide more services in remote settings where HIV numbers are low. And so this publication really resonated with the two studies that I was conducting, because again, it's American Indians and Alaska Natives are a group that don't have high HIV infection rates. But when we look at services around testing and treatment, and we look at just testing patterns at the individual level, we're seeing that there's substantial disparities within this group. And going back to the ending the HIV epidemic initiative, when we look at the regions where there's a focus, because they're considered geographic hotspots for HIV infection, Southern California the counties within Southern California are highlighted within this initiative because it's identified as a hotspot for infections. But in terms of the American Indian and Alaska Native population, it's an area that has a substantial presence of Natives. It's a region that has 33 federally recognized tribes. And again, recall that map I showed you earlier. It's also a region or metropolitan region that has a large number of Natives that self-identify with at least one tribe. So the third study, building off of those first two studies, was really an attempt to look at awareness and prevention within our rural American Indian tribes here in Southern California. And this is, again, an ongoing study, which is in its third year, but it's a multi-site collaboration between UCSD, Cal State San Marcos, as well as our Southern California American Indian community partners. And we've called this study Shaping Native Health, where shaping stands for STI and HIV awareness and prevention. And the overall goal of this study is to identify these local level priorities within our reservation communities so that we can create resources and services to address HIV prevention and treatment. And the aims itself, there's 4 involved here. The first is to look at community level perception, risk perception around HIV and STIs. The second aim is to look at the feasibility and acceptability of using different types of platforms to deliver HIV and STI prevention education. The third aim is to understand the individual and social structural conditions that affect HIV and STI related knowledge, attitudes around HIV and STIs, as well as behaviors that increase risk for HIV and STIs. And then finally, look at the local level infrastructure and resources within our Southern California tribes that are needed, these resources that are needed to implement HIV and STI prevention efforts. This 4-year mixed method study, again, is situated here in Southern California tribes. These tribes encompass a population of approximately 5,000 residents, most of them self-identifying as American Indian or Alaska Native. These Southern California tribes are also located in regions of Southern California that have had the highest rates of chlamydia and gonorrhea, which again is an indication of sexual practices that can increase one's risk for HIV. Some other characteristics about these tribes is that most of them are rural or remote, and therefore they have low population density. Being rural and remote also means that they don't have a lot of transportation options. And very often there's large distances between the tribes and their local clinics, where a lot of the local clinics are tribal health clinics. In terms of the data that we're collecting for this study to address those 4 aims I previously described, we're collecting both qualitative and quantitative data. And so the qualitative data is about obtaining people's opinions around what's happening within their particular tribe when it comes to awareness and prevention for HIV and STIs. And this is through the form of key informant interviews as well as focus group discussions. Unfortunately, since this is an ongoing study, the pandemic made us have to pivot our data collection. So a lot of what I'll share with you today is more from the form of key informant interviews, since focus groups had to be put on pause. And then the quantitative data, which we're currently starting to collect, is in the form of anonymous behavioral health questionnaires that are being administered to 300 members of Southern California tribes. And the purpose, again, of these questionnaires is to look at people's knowledge when it comes to HIV and STIs, their attitudes around HIV and STIs, as well as substance and sexual behaviors. So what I'll present on this study is some research that recently came out from our qualitative work that was published in the International Journal of Environmental Research and Public Health. So this is work that was led by one of our co-investigators. As was said earlier, I'm a trained biostatistician, but I'll do my best to present some of our qualitative work because I think it is really illuminating, in addition to what you've already seen with those first 2 studies, it really highlights what's going on within our Southern California reservations when it comes to HIV prevention and awareness. So there were 4 main narratives that came out of this qualitative work that impacted HIV and STI prevention efforts. And those narratives were around intergenerational and historical trauma, stigma related to HIV and STIs, this misperception of risk and lack of awareness. And then finally, a lot of mistrust in privacy was another thing that was discussed by participants. So for the, in terms of the historical trauma, what was discussed by a lot of participants was in the form of colonization and how colonization led to a disconnect from people's culture and their values. And so this one particular participant highlighted how colonization led to this concept of shame that hadn't existed before within their tribe. So as this person said, and the boarding schools did a really good job at, bringing the rest of the shame that we didn't have. And we didn't even have a word for shame in our language, prior. So I think that's a huge role in where we are at here, 300 years later, Another common narrative that came out that was more related to stigma was these comments around gossip that happen within our reservation communities in Southern California, and this concern about being judged by others. So as one person said, I think there's like maybe stigma with HIV. A lot of people know about it, but they're not really too familiar about it. Or if they have it, you won't really know. Or you'll hear someone, hey, you might have that. And so a lot of hearsay. Small community, word gets around. Yeah, what's like pertaining to each case. I don't know what it could be that kind of prohibits somebody from reaching out, but it's definitely like a stigma, being ashamed, not wanting to, I don't know, being judged. The fourth narrative that came out from a lot of our interviews was this misperception of risk. As one person said, I think for the community, it's not on their minds because they don't hear it, they don't see it, they haven't heard HIV/AIDS since the 90s. So people might be under the impression that it's been cured. And confidentiality was another issue that came up for many, particularly around privacy and mistrust. So this person said, but I think they're reluctant to come in if they know that they're going to see somebody they know. So sometimes it's because of our own families may not get the services they normally would because I might be checking you in the front desk. That might be a barrier. Or I might get my HIV medication from a cousin who works in the pharmacy. So this really highlighting the geographic isolation and tribal clinics being situated in areas where you have low population density, and so often receiving services where it's a family or friend that works within that clinic. And then, as I mentioned, our qualitative data collection was being collected during the pandemic. So last year we were still conducting our interviews, and I want to highlight some of the other findings that we started to hear last year in regards to how the pandemic was affecting HIV prevention efforts. So the first one is disruption to service and resources with COVID. Something that wasn't unique to the Native population. We heard this throughout the US. But as one person saying, there's just too much testing and hoops to jump through just for regular checkups and things. Some of our participants also that were interviewed last year were talking about or were mentioning how young people in particular were not taking the pandemic seriously. And they were seeing that relate to their sexual behaviors. There was a lot of mention during our interviews conducted last year around sex being used as a distraction, and that the pandemic was leading to bad decisions when it came to people's sexual partnerships. And then finally, we were hearing a lot also about the rise in substance use during the pandemic, with both adults and kids turning to drugs and alcohol. There was talks by participants about substances being unhealthy distractions, and some mentioning that they thought increased usage was happening because people were bored, but then also they were seeing more people in their community relapse because of fewer services. And what we were learning is not different than what we were seeing in the general population. So just here are some articles that I pulled around looking at disruption to services and how that was impacting HIV and STIs. So one article discussing, has STD rates dropped? Not really, it's just that there's not opportunities to screen during the pandemic. As well as these articles looking at disruption to HIV testing services during the pandemic. So things that we are hearing here in Southern California with our tribal reservations being echoed throughout the country when it came to disruption of services and the implications that had on HIV and STIs. In terms of implications across the three studies, just to bring all these things together, I saw some pretty common themes, and those themes being around structural barriers as well as interpersonal barriers. And in terms of structural barriers, seeing just limited testing services, both for those first two studies, the first looking at where are services in relation to our native population, and the second looking at testing patterns at the individual level. And particularly with that second study, seeing that sexual behaviors really didn't explain these differences in the native population versus the native population having an HIV test. But rather, probably what's going on is that for many of our tribal populations, they tend to be located in more remote areas of our county. And this isn't just for San Diego County, this is throughout the nation. Most of our tribes are in more remote areas, that populations tend to be sparse. And there's also a lot of geographic isolation, meaning farther distances to reach services. And then the other thing that brings these three studies together is interpersonal barriers around or challenges to HIV prevention and treatment. And so these barriers being stigma, privacy concerns, and just lack of awareness around HIV, that all of these are situated within this context in which Natives have endured historical and ongoing oppressions, which are currently contributing to these challenges that we see around HIV prevention and treatment. In terms of challenges, just some of the lessons that I've learned so far in conducting this work over the past few years is first with data challenges. I mentioned earlier with that CDC report of recommendations for improving surveillance of HIV within the American Indian Alaskan Native population, but one of the issues being small population sizes and just suppression of numbers. Even here looking within our county and trying to get some of this data from our county department when it comes to HIV, very often we don't see Native Americans presented in those surveillance reports. The other thing is racial misclassification and collapsing of racial categories. One of the limitations I saw in that second study where we were looking at HIV testing patterns amongst Native and non-Native cisgender women is that many of our Native women also self-identified as Hispanic. And it's very often for anyone who identifies as Hispanic just to be lumped into one category without acknowledging or trying to tease out this more nuanced issue going on of multiple racial and ethnic identifications. And then the last part in terms of challenges is just the need to develop these culturally adapted interventions. We're midway through that 4-year study, and I shared with you some of the qualitative work from that first paper that came out of that 4-year study. And we've shared that qualitative work with several of our tribal partners. And I remember being in one conversation with a tribal council, and a tribal woman was very concerned on how we were presenting our information, because very often Native populations are pathologized. And what's seen within Native populations is, what's the problem? How do we fix it? Instead of coming at it as this is a resilient population, what are the strengths within these groups, and how can we develop programs that recognize that resiliencies and those strengths? And so one of the challenges is the need to develop these culturally adapted interventions that highlight the resiliency and look at culture as medicine towards addressing HIV prevention and treatment. And then the last part being tribal diversity. Because tribes have their own issues, it's hard to develop a program where it's one size fits all. So again, going back to this ongoing study where I'm working with multiple tribes, I recall working with one tribe where their problem around substances is primarily alcohol and nothing else. Whereas for another tribe, they're dealing a lot with opioid fatalities as well as methamphetamine use. So trying to think of interventions when it can't necessarily be a one size fits all is another challenge here, in addition to a lot of these tribes just being small in population size. So with that, I'd like to thank you for your time and for listening to me present some of my work that I've been conducting here in Southern California, and open it up for questions.
Tommi, thanks so much for really a very compelling and thoughtful talk. I will open it up. I could ask something, but I'd love to extend it to the group. Oh, maybe someone's trying to speak. Dan.
Yes. Hey, thank you, Tommy, for that. I just, I've been in HIV care for 22 years now, and I think this is the first talk about American Indian and Native Americans that I have heard, which is a little bit sad, but at the same time, I'm glad that you're doing this work. So thank you for your work on all this.
Yes, thank you. Yeah, it's definitely a hidden population when it comes to the HIV epidemic, but a population that shouldn't be overlooked, knowing that there's substantial disparities going on here.
Tommi, I don't know if you have been able to explore this, but certainly I was thinking about distance from where people live to testing sites. Now that we have telemedicine and we've sort of seen that explode during the pandemic, it would seem like there are more opportunities to engage people that way. Is that something that you've talked about, explored? Looked into it all with your work?
Yeah, so the nice thing is with an ongoing study, we have been able to incorporate some of those questions. So we haven't looked at the data yet. I can't really speak upon that, but just anecdotally speaking with some of clinic staff, we've heard that there was a slow rollout of telemedicine for people to understand how to utilize this and how they could receive care through that route. We're now starting to interview participants to see how they're receiving it and whether they think that this is something that could stick around for the long run. But one thing that we do need to consider for some of our tribes here in Southern California, because of their remoteness, there's not always reliable access to internet services. And so I think this is something that we're going to have to think just for rural populations in general, that this is a really great resource. But again, it's probably not for everyone. And it goes back to this idea of one size doesn't fit all. So in addition to telemedicine, seeing what other things could be implemented, such as mobile clinics. Mobile clinics have existed within some of these tribes before, but are more tribes willing to engage in mobile clinics now that telemedicine is around? So we're also exploring that to see, once a community is introduced to one way of delivering health, can we also introduce other ways of delivering health that may do just as well of a job?
Thanks. There is a question in the chat, and I love it, Dr. Shannon Balcom. Thank you for the examples regarding differences between tribes on substance use. Do you have any other examples of how to tailor interventions between tribes and how cultural sensitivity can be implemented? That's not a big question at all.
Yeah, so a lot of this is working with your community partners and finding out what's going on and what they're in need of in terms of their substance use or sexual health behavior programs, what resources they currently have and what resources they think they need. So it's really, working with tribes is really about doing community engaged research. It's hard to take something that has been found to be efficacious, for example, intervention that may have been found to be efficacious within one population, and try to adapt it within another without really having that community engaged research. And just here within San Diego County, I've worked with a couple of our San Diego County tribes now, and there have been a lot of substantial differences when we talk about substance use. I mean, from alcohol use to some tribes are dealing with whippets, using the cans to get high off of, whereas others, it's more about methamphetamine. So it's really about going into tribes, developing those relationships, having your tribal partners contribute equally because they know what's going on the ground more so than we do, and then trying to figure out what interventions might fit best. Can we adapt something within this community, or do we need to start from the ground up because what currently exists won't suffice?
Soon to be Dr. Nicole Pepper wrote, thank you for highlighting that those of us who work with Hispanic, Latino populations are working with individuals who have Native Indigenous identities. And for highlighting resilience, research often overlooks that.
Yeah. Yeah, thanks for that comment. I think looking more at upstream than downstream is one way that we're going to engage our tribal. Because we know that we're thriving as a community, so why not focus on that and use our assets to develop these promotion campaigns or interventions rather than just focusing on the problem.
I mean, it definitely strikes me a lot of what you talked about in your work is very emblematic of what we hear in other work, as you sort of said, with other populations, that have been marginalized. But obviously each population is unique and has its set of needs. So I don't know if this is a question you can answer, how can we take what we're learning from individual populations and try to help more broadly apply that so that we can, scale up our interventions and the things that we do for various groups?
Wow, yeah, that's a big question, Jill.
Because if I closed my eyes, right, I could have said, "Oh, this might be about another group that we talk about," but really, it's how we then deliver it, or deliver what we want.
Yeah, one of the things that I'm starting to learn here is that goes to how do you scale up? Is that for marginalized groups, they're often in crisis mode. There's often a lot of things going on where it's like, okay, we're going to focus our attention on this right now because this is what's happening. And then there's the next crisis that happens that we really don't fully address that previous crisis. And so I think part of it in terms of scale up for marginalized groups is how do we manage these multiple crises and still provide programs and services where we can look at all this we consider all these multiple challenges going on at once rather than just focusing on one issue. Okay, that's somewhat died out. Let's focus on the next one, but that issue's still there in the background. Now that I haven't figured out, but that's a feature that's common in a lot of marginalized communities, whether it's chronic illness, mental illness, interpersonal violence, substance use. It seems like these are common elements that I keep on hearing, that they never really go away. It's just, this is where we're at in this moment. This is our crisis. This is what we're going to focus on. And it's still there once we move on to something else. The other thing too, and I don't know, this is probably going beyond what you're asking, it's just the funding. I'm noticing too that where what tribes tend to prioritize often follows in line with funding. But we too, as researchers, do that, right? It's like what's being set as the priority for funding, and that's what we follow. So I think that's another thing to think about with not only dealing with multiple crises, but also funding issues.
It's a very thoughtful answer, so thank you. More questions in the chat have come up. So from Jessica Montoya, great presentation, Tommi. The data indicating that most American Indians, Alaskan Natives live in urban settings and not on reservation settings. How might we identify and reach these individuals? Have any of the tribes in Southern California identified ways of reaching their members who do not live on tribal lands?
Yeah, that's a really excellent question. So we do have our urban Indian health clinic here in San Diego, and a lot of areas that have large populations of natives within metropolitan settings do have the urban Indian health clinic. So that's one way, is through our urban Indian health clinics and partnering with them. But also too, with a lot of our tribes, people, even though they don't live on the reservation, they still do frequent their tribes. I mean, people still have ties culturally to their ceremonies and their gatherings that are happening on their tribes. So even though they might not reside there, there's still opportunities to disseminate information to the tribes, which eventually reach those urban members. So for example, Several tribes have their own newsletters, and that's one way to engage tribal members that aren't living on the reservation, but that still access that information through newsletters. So myself being Navajo Nation has their own newsletter, and that's how I could find out what's still happening within my tribe, despite me being miles and miles away here in Southern California. So there are opportunities through our urban health clinics, but then also just through utilizing resources that our tribes already have going on, because we know a lot of our urban tribal members return back to their tribes or still engage with their tribes one way or another.
Thanks, Tommi. And I think we have time for this one last question from Judith Lobo. Did you observe age differences among tribe members in adopting HIV prevention practices? I would think a younger population might be easier to adopt, but some of your qualitative answers suggest the COVID-19 lockdown might be a barrier.
Yeah, so we intentionally did not collect demographic data with our qualitative work. So I can't really say how those responses tease out age-wise. And we intentionally did so because a lot of our data, again, we were working with tribal reservation communities in Southern California. And there was already this concern of, everyone knows who I am, and I don't want people to know that I was part of this interview. And so we limited what demographic data we collected. That we should be able to see though with our survey data, but we don't have enough responses yet for me to stratify that by age groups. But eventually we should, because we are collecting 300 surveys. So hopefully we will be able to answer some of those questions, just not right now.
Thanks, Tommi. I think you've got a lot of praise coming in for, again, a very insightful presentation. And for many of us, this may have been the first time we're hearing about this. So, thank you so much for sharing your data and your work as it goes on. And we look forward to having you back and hearing more in the future.
Yes, definitely. Well, thank you again for inviting me to discuss some of this work and bring the Native population back to the table when it comes to the HIV epidemic.
Thanks so much, Tommi. And we, not to take anything away from Dr. Gaines, we have a very great speaker next week. One of our first external speakers, I believe, of the year, Dr. Leandro Mena, who was brought by Elliot Welford from his alma mater, University of Mississippi Medical Center. And he's going to be talking about culturally competent HIV prevention and care for Black MSM in the South, I believe. So it should be a really interesting presentation, and we hope everyone will join us next week. But have a great Friday, a nice weekend, enjoy the sun, wear your sunscreen. And that's it. Bye, everybody.